We have Derrick and Tony that are actually with us. Derrick has a really interesting story at the beginning of COVID, and this is where we first really got in touch. At the beginning of COVID, his hospital vascular surgeon in Chicago said, well, yeah, your foot probably needs revascularization, but nope, can't do it. So, come back in a few weeks and we'll just amputate it because we'll likely have to do that anyway. And so I got connected with Tony and I said, hey, Tony, his wife, send him up to Dr. Jihad Mustapha, who's one of the top Pitaluke specialists. And she did, and his legs are saved. And both of them, in fact, just a week ago, I believe it was, and Tony and Derrick, correct me if I'm wrong, but you just had the other leg, the other foot saved from amputation.
Just a week ago on Monday, they went in the right leg and went all the way down in the foot, what's left of my right foot, and they opened it all up.
Can you give us just a brief version of your story and how you got to where you are today? I mean, you've already lost, you said, a few toes, but we've been able to salvage your foot just in the past few months.
Yeah. It started with my right leg back in 2018, was it? Mm-hmm. I think back in 2018, to me, it felt like I was getting cramps in my thigh. In fact, one time I was backing up in my driveway and I was getting out of my truck and I went straight to the ground because my leg cramped up so bad. I couldn't get up. I actually laid there for a little while. And Tony had to run out with some magnesium spray and spray on my leg just so it would loosen up so I could get in the house. I didn't realize it was actually because of, being, plugged up down below there. And we eventually went to Chicago for all this. And at first it was like my toes were starting. I must have got a sore or something on one of my toes to start with, and I didn't feel it. And it just went necrotic. And it had to come off. I know that one had to come off because it was dying. And eventually, that's all that they did for me was just, okay, that one's bad. That one's got to go now. And not a single one of them in Chicago even gave me any other options other than cutting them off. So I ended up losing 3 toes on the right foot and a good chunk off the top of my foot and the bottom of it. And so that toe is like an alien toe now. That's what I call it now.
And when was your first revascularization?
The first one was early this year in, what was it, March? It was
so
in
this
March,
was, you didn't even have the revascularization before they amputated?
No, they didn't give me that option at all. They didn't even say anything like that. They said nothing to that effect whatsoever. They just were talking about cutting it off, and that was it.
They would send us to the podiatrist. The podiatrist didn't want to deal with the wound, so he'd send us to the vascular. So they ping-ponged us back and forth. And finally, by the time we actually got help, we had gangrene, we had necrotic tissue, and we had a foot or / leg that was getting ready to get amputated.
And that was early in March, so COVID was just starting to hit. That's why the doctors in Chicago said, oh, we'll do a video visit. I'm like, well, that's not going to do nothing. I need help now, because my left foot was going necrotic. I had dead tissue on the side of the foot and everything.
Gangrene.
Yeah. And so Dr. Mustapha's nephew, Dr. Saab, went in the left leg and went down. And those sores that were on the left side of my left foot are damn near completely healed up now.
They're not only equipped to get into the small arteries and restore the blood flow, but you're not at the mercy of the hospital and the regulations with their time constraints. We've noticed that we've gotten better care. They're obviously more specialized in their treatment and are able to get into those arteries and unblock the arteries and really open up the leg for the blood flow, especially for the diabetics. And so you're really getting a much better level of care than you would get in a hospital.
But what's amazing is that you acted and once you had, and I think it's so telling that once you had those revascularizations, both feet are intact and wounds are healing. But it's also in part because you had a great relationship between a vascular specialist and a podiatrist, and you immediately after that revascularization of that at the arch of the foot, the pedal plantar loop, that you were able to get to that the foot specialist, and you were able to get the debridement right away.
Yeah, it was like 2 days later is then when I went to the podiatrist, and he did some debridement and everything and said it was actually looking pretty good already. So
Yeah, within 2 days
Yeah.
of getting revascularized and getting that blood flow to the foot, you could have seen immediate changes
hmm
in the skin and the wound. So yeah, it is very important.
yeah.
And it's also important, I think, that when you're dealing with wounds, even if you don't really know what to do with the wound, always keep it covered, keep it moist, like
keep
with like
it
a
clean.
petroleum. We use something called Zero Form that we saw for, we use from the wound care specialist at Rush. And that's what I do now. I just make sure that that the wound is clean daily, and then it gets covered with some kind of covering that doesn't let anything get inside the wound.
hmm
What do you think that physicians and innovators can learn from your experience to help improve, especially wound care for other patients going forward?
Well, Derrick had an emergency appendectomy. He had his appendix out
Couple
and
months ago.
a couple months ago, and
That was fun.
they wouldn't let me in the room because they said, well, COVID and all that. So I said, well, are you changing his wound pads on his feet? And they weren't changing his wound pads. In fact, the nurses were saying, oh, well, we're not used to dealing with the wounds up here. And so by the time they unwrapped the wound, I could see the whole side of the foot was getting red. And I was like, whoa, wait a minute, hold the phone.
They had left me when I was in for the appendix. They had me laying there for about 5 days before they even unwrapped my foot to even look at it. And I'm like, this needs to be changed daily, and they just weren't doing it.
So finally, I actually had to bring stuff from home to the hospital, and Derrick had to walk the nurses through the wound care in the hospital.
Mm-hmm.
The story, Derrick's last story really highlights, unfortunately, how specialized, especially in large hospitals or, these really, the advanced hospitals, everyone is so specialized, they've got blinders on, right? They're very focused on what they're doing. So I'm assuming the general surgeon who took care of the appendix, that's all they saw, right? So it was actually, unfortunately, they weren't listening to you. They should have brought in, podiatrist or vascular specialist to help address your foot wounds because they were active issues that needed to be addressed. So unfortunately, that didn't happen for you. But it happens far too often, and it's really hard to see. And sometimes, you just need that advocate. And I'm really glad to hear that you're your own advocate.
It may be there's so much variability in care in different facilities, even really wonderful, renowned facilities, even depending on what ward you get on, because this is why you'll often see that individual clinicians, be they a nurse, a physician, a surgeon, a therapist, they can make an enormous difference, and they can sometimes your feet really are killing you, and especially if you ignore them. And so you don't need me to tell you this. You clearly did the right thing. You were your own advocate, and you started change. Well, you didn't even change them yourself. You were walking the nurses through that. But ideally, what these centers need, I think every hospital needs a certain level of kind of limb preservation unit in them. And we've actually labeled these things just like you've heard about trauma centers, you see the helicopter landing at a level 1 trauma center, like right behind me at our hospital here. We actually have level 1, 2, and 3 for the high risk limbs as well, so that nurse, she knows or he knows when that shows up, to just call and have those folks descend on your foot and have a look at you. And sometimes, even though you're just in for your appendix, you might need an angiogram, angioplasty, and all the wizardry that you've seen here and geographically and clinically.
When you've gone through so many procedures and you have the necrotic feet and wounds healing, and there's so much, Dr. Alame, what are the next steps to get, Derrick on his feet and start exercising? We have our coach Susan who's ready to take him on and get him moving, but where do we start? Because I would think that it's really hard that once you've gone through all that to get back moving again.
So I think, whenever there's a lot of data speaking about how the benefits of exercise, even post-intervention, there's a lot of data out there to show that, the exercise will help prevent the need for re-intervention. Now, a lot of that's around claudication, less around patients with wounds. But once it's safe to walk, your wounds have healed and you've gotten the sign off to, be able to be weight bearing on that side. I'm sure are you non-weight bearing right now, or?
No, I'm walking. I'm actually walking fine, really.
Oh, you are? Okay. No,
I think
fantastic.
he's even walking the dogs. I think Tony has him walking the dogs now. Yeah.
Yeah.
Yes,
I took him on a 2-mile rugged trail that was
That's phenomenal.
intensive.
So as long as you're wearing the right shoes and you're protecting your feet and not causing injury, by being too hard and rough with the walking, there's so much data to show that, this will help prevent your freedom from the need for re-intervention can be really extended. And in the Netherlands, they have a lot of data around this because they actually require folks to go through this rehabilitation walking phase even before they offer intervention. And so they have a lot of data to show the benefits there. So, I can only encourage you to do as much as you can. I mean, the guidelines say, 30 minutes at least, 3 times a week for up to 150 minutes. But if you can go 30 minutes to an hour a day, 5 days a week, something like that, it really does help.
Yeah, I couldn't believe those pictures that I just saw that Tony and Derrick posted of a really rugged trail that they went on. I mean, the relief, Derrick and Tony, that you must have felt with every single step.
Well, I just want to really give a really special shout out to Dr. Gupta, Dr. Mustapha, Dr. Saab, Dr. Petrone, and all of these innovative doctors that have really made enormous changes for us suffering from this disease, because people never really address the mental anguish that somebody goes through when they're facing amputation. When Monique said she gets up in the middle of the night, has to hang her legs. I mean, it's all of these quiet times where, you're suffering in silence. Yeah. I mean, that these wonderful doctors that have gone and made such a huge difference in our lives. I mean, we wouldn't be walking, we wouldn't be doing anything. And the thought of being in a wheelchair or losing a limb, I mean, and really some of the doctors at the hospitals, I know they feel bad for you because you can tell they do, but they just don't have anything to offer you other than just go home and let things happen the way they're going to happen.
Yeah, Dr. DeMestrel, that must be a really tough spot for physicians to be in, that sometimes your hands are just tied. I mean, some doctors, not saying you, but some doctors end up kind of turning their cheek and going, God, I wish I could do something. I really can't. So you just have to send them home with pain medication. That must be very, very frustrating, which is why I imagine that you're taking a more proactive approach to change the rules and to find new innovation and get things done up there.
I think the solution also is working in teams. And I was hearing you describe, going back and forth between the podiatrist and the vascular surgeon. In an ideal world, you'd have everybody of relevance in the room together when they're seeing you. And I think that's what happens in some of the most advanced limb preservation clinics. Yes. It can be challenging logistically, but from a patient's perspective, it makes total sense that everybody comes to you rather than you bouncing from clinic to clinic. I think also, plans can be made as a team, and that's hopefully what we can move towards more widely.
I want to bring in Jason Costello really quick. He hasn't said very much. He has all of his research. He's going to be innovating hopefully very soon. Jason, what are your key takeaways? What are you going to create for patients now?
I'm not too sure yet, but there's some very interesting points there. I'm just interested in what maybe Dr. Armstrong's perspective is on. I know you were saying that, let's say a patient is at the primary care level or GP and they could take off their socks to show the GP, but what about situations where that doesn't happen? Like, do you feel like a lot of patients slip through the cracks? Is there any way to interrupt that progression?
Yeah, Jason. Well, I think the way to do that is exactly what you heard Derrick and Monique already talking about. I think everyone talking today is talking about be your own advocate, BYOA, I guess. But if we have an acronym now, but I was actually going to ask you a question, but I'll hold off on that quick question and I'll answer this. You know, we did a study some years ago looking at how often the foot was evaluated during a GP visit or even on an inpatient visit. And on a GP visit, it was on the low end evaluated about 15% of the time. On the high end, just under 20% of the time on a regular kind of ordinary diabetes visit. So that was outpatient. On an inpatient basis, remarkably, and this was many years ago, and it's improved a bit, but for people admitted to hospital with a diabetic foot complication, with a primary diagnosis of a diabetic foot complication, they got just a very basic exam, and we just called a basic exam saying where the wound was and if they felt for pulses. That was it. That happened amazingly. I believe it was something like just under 14% of the time. That was a paper out in the Archives of Internal Medicine. But the thing is that people just ignore this because it's often asymptomatic until it's not. And so these are horrible acute on chronic complications that we have to stop. But I was going to ask you a quick question, because one thing that you might want to track as you're trying to track some of these patients, and you can even maybe use some of the power of the app that Oliver has developed with SVS, with the benefits of exercise, but on mood, because, you know, more than half of the patients that we treat are clinically depressed. And we may not even pick that up because, first of all, I don't even think we know what the heck we're doing as physicians or surgeons, as much as we think we do when it comes to behavioral health. And having maybe something like you looking at this and following it and really paying attention to it when a lot of other folks just don't have time to do that, or the experience, it could be really, really important. One of the best things we've ever done was bringing behavioral health specialists into our unit. And it is spectacular, along with nutritionists. But the behavioral health folks that we have in our unit are not psychiatrists or psychologists, because they are so busy for obvious reasons with people with, you know, really, really horrible problems, suicidal and homicidal ideations and whatnot. But we've actually had occupational therapists in our unit that have a lot of training in behavioral health, and they've really helped us dramatically, and they can triage people into other more advanced behavioral health as needed. I'm sorry to go off on that, but I wanted to ask you if you'd actually look into behavioral bits and pieces.
Yeah, no, that's a very good point. So I suppose I've just been reading a couple of papers the last couple of days, and there's plenty of evidence out there for the benefits of maybe identifying, let's say, highly stressed patients along the pathway, and, you know, putting a little bit more time into them. I think it's a very good idea what you're saying. I'll definitely look into it more.
And then maybe you can, if you had a pedometer on the same device that you were tracking someone with an app, maybe you could then equate maybe activity per day with mood, because I think maybe one of the other underlying benefits of the work that Oliver et al. Have been doing, it might be that, you know, going out for a walk has a tremendous effect on your constitution. That's why they call it a constitutional, you know, getting out and getting a walk.
You know, and I think that, you know, going back to what you said a moment ago, Dr. Armstrong, you know, and I think this whole behavioral thing is really huge, because I was just talking to the chief marketing officer for Modern Vascular here in the US yesterday, and we were discussing the fact that there's so many patients that have PAD that are clinically depressed, and there's a very high cancellation rate, not only for clinic consultations, but also procedures. They can't depend on so many, and that's worth looking into as well. So I really appreciate everyone for being here.
Thank you, everybody.
Thank you.